Hi, Mr. Francisco. My name is Cynthia. I'll be your student nurse practitioner performing your head, eyes, ears, nose, and throat exam. And would you consent to being videotaped and uploaded in YouTube as unlisted for educational purposes?
Yes.
Okay, thank you. So I went ahead and washed my hands prior to the recording of this video. So we're gonna go ahead and get started on our examination. The first part of the exam is going to be the head. We're gonna go ahead and examine the distribution and the texture of the hair. Okay. Then we're gonna look at the scalp and we're gonna look for any dry, scaly patches, any redness, any rashes. Okay. Next, we're gonna go ahead and palpate the head. We're gonna check for any depressions, any lesions, any tender spots. And we'll also check for the occipitus. It should be protrude. Okay, so the head examination looks good. Now we're gonna go ahead, while we're on the head, we're gonna go ahead and look at the face. We're gonna check to make sure that there's no lesions, especially around the mouth area, like herpetic lesions, any unusual spots on the face, any discolorations, no lacerations, nothing unusual in the face. Now we'll go ahead and move forward with checking the sinuses to see if there's any tenderness in the sinus area. So we're gonna check the frontal sinuses, and you let me know, Mr. Francisco, if you feel any pain or tenderness, okay?
Okay.
Okay, now the maxillary. Okay, now there was no tenderness, no pain in the sinus area. So now we're gonna go ahead and move on to the eyes. We're gonna go ahead and check for acuity, vision acuity. And the way we do that is we will start with the Snellen chart. Now this is a pocket Snellen chart. In this, we test 6 feet away from the patient. If we would be in a doctor's office with the regular Snellen chart, it would be 20 feet. But because we're using the pocket chart, then we'll do the 6 feet. So I'm gonna go ahead and walk 6 feet away from my patient. Okay. Now, Mr. Francisco, I'm gonna go ahead and have you cover your left eye. Go ahead and read this line for me, please.
EPTZO.
Okay, and the next line?
CFDHJ.
And the last line?
LTFPH.
Perfect. So you have 20/20 vision on your right eye. Go ahead and cover your right eye. Okay, go ahead and read this line for me.
EPTZO.
Okay. The next line?
CFDHJ.
And the last line?
LFPH.
Okay. So you have 20/25 vision on your left eye. Go ahead and uncover both eyes. And we'll go ahead and look at this line and read that for me.
EPTZO.
The next line?
CFDHJ.
And the last line?
LTFPH.
Okay, so you have 20/20 vision on both eyes. Okay, so next we're going to go ahead and test for peripheral vision confrontationally. And the way we're gonna do that is we're gonna test each eye. So we will go ahead and test the left eye first. And let me know, Mr. Francisco, when you see the flickering of my fingers come to your vision.
Right there.
Okay, now we're gonna do the right eye.
Right there.
Okay, now we'll do both.
Yep, right there.
Okay, perfect. So you have intact peripheral vision. Now what we're gonna do next is we'll be inspecting the eyes. We're gonna look for any crusting in the eyebrows. We're gonna look for any crusting in the eyelashes, any discharge, which I don't see any. We're gonna look for exophthalmos, which is the protruding of the eyeballs. That would indicate any problem with the thyroid. We're also looking for any drooping of the eyelids and the ptosis, and I don't see any of that. Now we're gonna go ahead and inspect the inner of the eye, the inner eyelids. We're gonna look at go ahead and look forward at the conjunctiva. It's nice, pink and moist. The lacrimal glands look well, no discharge. The sclera looks good, it's white. And open your eyes wide. And the lenses look good, there's no discoloration there. Okay. So next, we will be looking for direct light reflection, we're gonna look at the pupil and look at the direct light reaction. And what we'll do is we'll get our pen light and we're gonna test to see if the pupils react to direct light, to see if they accommodate or constrict to the light. So we're gonna start with the pen light at the side of the head. We'll look at the left eye first. Open your eyes forward, look forward, and then we'll gradually move to the left eye and we can see that the left eye pupil constricted, round, and reactive. Okay, now we're gonna do that with the right eye. We'll start on the side and gradually move forward towards the right eye. And we see that the pupil constricted, it's round and reactive, and it was reactive to direct light. Now we're gonna go ahead and test for consensual reaction to light. And the way we're gonna do that is, we'll do the same thing. We'll go ahead and start on the side of the head, move towards the left eye, look forward, open your eyes a little. And we see that the opposite eye, which is the right eye, the pupil did constrict, it did react. So that's consensual reaction to light. We're gonna do the same thing with the right eye. And the left eye, which is the opposite eye, did react consensually to the light. Okay, so now what we're gonna do is we're testing for extraocular motions. So we will be testing the cranial nerve number 3, 4, and 6. The third cranial nerve is the ocular motor, and the fourth is the trochlear, and the sixth would be the abducens. And these cranial nerves, what they do is they are in charge of moving, for eye movement, moving the eye. So we're going to go ahead and start with the test and making sure that all of the cranial nerves are intact to move the eye. So Mr. Francisco, you're going to go ahead and look at my finger and follow my finger. And as we're doing this, we're looking for any nystagmus, which are rapid eye movements of the eye, which is not normal. Now to the left. And now to the middle. Okay, now we will be testing for convergence of the eyes. And the way we do this is we put the finger in the middle. Look at my finger, Mr. Francisco. And as I get closer to your nose, just keep track of my finger. Keep looking at it until it almost touches your nose. Okay, so I noticed that there was convergence of the eyes, and that's normal. So that's what we want to see. Now we will be testing for accommodation. Now the accommodation is when the eyes accommodate, when you're looking at far vision and then focusing on something closer. Your eyes, your pupils will accommodate to the difference in distance. Now we should see some constricting of the pupils when the eye switches from long distance to short distance. So go ahead and look at my eye, my finger, Mr. Francisco. Now focus on an object far on the wall there and look back at my finger again and again. Okay, so there was good accommodation there. His eyes did accommodate, or his pupils accommodated from far to close vision. So we have normal findings there. Okay, So now what we'll do is we're going to go ahead and test the red reflex in the eyes. And with the red reflex, what it does, it's testing to see if there's any abnormalities in the lens and the cornea. So what we'll do is we'll use the ophthalmoscope. Now, it is very important, the technique that we use is, so there's no unusual bumping of the face, because as we get close to the patient's eyes, we will be rather close. We don't want bumping noses, bumping faces. So what we do is, whatever eye you're examining, for example, if I'm examining the right eye, I will hold it with my right hand, and from my right eye to the patient's right eye, we will be examining, and then vice versa with the other eye. Left hand to the left eye to the patient's left eye. So I'm going to go ahead and get started on the right eye. So I will be holding the ophthalmoscope with my right hand. We'll be looking into Mr. Francisco's right eye with my right eye, and we'll be looking for the red reflex. Now we want to make sure that we see that red reflex. Okay, I see the red reflex, and I will be approaching, getting closer. And I will be looking for structures in the eye. The cornea, we want to make sure that there's no abrasions in the cornea or lens. We want to make sure that we see the optic disc and the optic cup. We want to make sure we look at all the no hemorrhaging, that we look at all the blood vessels. Okay. And all the elements of the eye are there, and everything looks good. Now we're going to be checking the left eye. Now I will switch to my left hand, the ophthalmoscope. We'll look from my left eye to Mr. Francisco's left eye. We're checking for the red reflex, and I see it there. Okay, so now we're getting closer. We're going to get closer. Okay. And we're looking at the cornea. It looks good. No abrasions in the lens or cornea. For the optic disc and optic cup is there. The blood vessels look intact. No hemorrhaging. So the eyes so far look pretty good. There's been no abnormalities there. Now we're moving on to the ear. So with the ear, what we're going to do first is we're going to be testing the cranial nerve number 8, and that's the nerve that is responsible for hearing. The way we're going to do that is I'm going to start with the whisper test, and I will, when I cover Mr. Francisco's ear, I will say a 2-syllable word, and then he will repeat what I say. So we're going to go ahead and occlude the left ear. All right.
Popcorn.
Okay. Now we'll go ahead and do the right ear.
Movie.
Okay, perfect. So he was able to hear both words on each ear. So that's good. So now what we're going to do is we're going to move on to conduction hearing testing. And we are going to use a tuning fork. We're going to do the Weber test, perform the Weber test on Mr. Francisco. And we will be placing the tuning fork after we strike it on an object, and the vibrations. We will place the tuning fork above his, it could be either on top of his head or on top of his forehead, which in this case, I'll go ahead and use the top of his forehead. So he'll be able to tell me whether he hears the sound and whether he hears it in one ear or in both ears. And this is the Weber test.
Both ears.
Okay, perfect. So he has normal conduction hearing at this point. Now the next test that we're going to perform is the Rene test. Now that will be testing for bone conduction and air conduction. Now, what I'll do is I'll strike the tuning fork again, and we'll place it behind his, each ear, of course. We'll be placing it behind his left ear first. So I'm going to go ahead and strike that. Do you hear that?
Yes.
Tell me when you stop hearing it.
Stop hearing.
Okay. Do you hear that?
Yes.
Tell me when you stop hearing it.
Stop hearing.
Okay. So what it is we placed the tuning fork as soon as he stopped hearing it on his back of his ear, behind the bone, the bony prominence behind the ear. That's bone conduction, and right away we placed it next to the ear, and he was able to still hear it even though he stopped hearing it behind his ear on the side of his ear, because air conduction is greater than bone conduction. So air conduction would be in this part here in front of the ear or by the ear, and the bone conduction was behind his ear. So now we will be repeating this again on the right ear. Tell me when you stop hearing it.
I stop hearing.
Okay. Can you hear that?
Yeah.
Tell me when you stop hearing it. We're placing it right next to the ear for air conduction.
Stop hearing.
Okay, so he was able to hear both the air conduction and the bone conduction. And like as I mentioned earlier, air conduction is greater than bone conduction. So everything was intact there. So our next step will be to inspect the ear. We're going to go ahead and look at the auricle of the ear. If you can turn your head, Mr. Francisco. And we will make sure that there is no crusting, no redness, that there's no discharge. We're going to go ahead and try the tug test, which is pulling the pin up and back. Do you feel any pain?
No.
Okay. So if there was any pain there, that would signify that there's a possibility of there being inflammation or infection, something going on in the ear. And so now we palpate the ear, the outer ear. Now the tragus, which is this area right here, we're going to palpate that. Usually if there is anything going on in the ear, this would be extremely painful. Okay. So next what we'll do, since we're working on the left ear, we're going to go ahead and take a look at the ear with the otoscope. And we'll go ahead and turn the light on. And for safety purposes, what we'll do is we will anchor our fingers against the side of his cheek there, so that keeps us from going too deep into the ear and from hurting his ear. So we're going to go ahead and pull the pin up and back. We're going to go ahead and look inside. We're going to look to see if there's any bulging, any redness in the ear canal, which I don't see any. We're going to see, and the color actually looks pretty good. It's pearly white, which is the normal. And I see the cone of light there too. And it looks to be at 500, 500. And then the tympanic membrane looks good. There's no swelling. The malleus, we look to see if all the bony prominences are intact, which they are. I don't see any drainage either. So everything seems to be intact in the left ear. Okay, so now we will move on to the right ear, and we will do the same thing. We will go ahead and inspect the right ear. And I don't see in the auricular area, I don't see any redness, any crusting, any drainage. Everything looks intact. We're going to go ahead and do the tug test, pull up and back. Any pain?
No.
Okay. Now the tragus, we're going to go ahead and touch the tragus, make sure that there's no pain there. which there isn't. As I mentioned, if there was something going on in the ear, there would be extreme pain there. And of course, we're going to palpate the ear. Okay, now we'll take a look inside the ear. Okay, once again, we're going to go ahead and anchor our fingers against the cheek so that we don't go deeper than we should. The pin up and back. Okay, and we're going to take a look inside. Okay, I see some cerumen in his ear, which is pretty normal. No unusual drainage. It looks pretty white. There's no bulging, no redness, no discharge. The tympanic membrane looks good. I see the cone of light, and it looks to be at 900. And the malleus and the bony prominences are intact. Okay, so the ear looks pretty good. I don't see any abnormal findings in the ear. Okay, so after the ear, we're going to move on to the nose. The nose, we're going to go ahead and palpate the nose. Everything looks good. I don't see any deviation in that bony area. There was no discharge, no redness prior to my inspection or prior to my palpation of the nose. Now I'm going to go ahead and inspect the inner nostrils on each side. So Mr. Francis, I'm going to have you pull your head up. Let me change the otoscope tip here. Okay. If you were sitting on a regular bed, I would be anchoring my hand on his forehead, but because he has where to rest his head, we don't have to do that. So he's making it a little easier. So we're gonna go ahead and pull the nostril up. We're gonna look at the left nostril. We're gonna look to see if there's any deviation of the septum, any polyps. I don't see any. The turbinates look good. They don't look swollen, no drainage. Okay, now we're gonna look in the right nostril. Okay, just so you can see. Okay, so there is no drainage, no redness. Oh, and also no bleeding. Sometimes you may be able to see some remnants of blood, but I don't see anything there. The turbinates are good. They're not swollen. There's no polyps. No septal deviation. Okay. Okay, Mr. Francisco, you can go ahead and, rest your head there. Okay, so now we will be testing the air passage of the nasal area. So I'm going to go ahead and occlude one of the nostrils, the left nostril. Go ahead and breathe in, Mr. Francisco, and out. Okay, good airflow there. We'll do the other side. Breathe in, breathe out. Okay, so there was good airflow in both passages. Now what I'm going to have Mr. Francisco do, he will close his eyes, and I'm going to go ahead and occlude one of the nasal passages, and I'm going to place an odor under his nose, and he will tell me what he's smelling. Okay, what is that? Take a deep breath and smell.
Coffee.
Okay, we'll do the same on the other side. Go ahead. Breathe deep. Smell.
Coffee.
Okay, now you can go ahead and open your eyes. So he was able to determine what this was, coffee in this cup. Okay. So we will now move on to the mouth. The mouth, as we had looked at before, we just want to make sure that there's no lesions around the lips. They could be hepatic lesions. There's no crusting on the lips. Everything looks good. I'm going to go ahead and change to my ophthalmoscope. I'm going to look inside the mouth. Okay. Now go ahead and open your mouth, Mr. Francisco. Lift your head up. And pull your tongue down, down. Okay, I'm looking at the tonsils. I don't see any redness, any swelling of the tonsils. I don't see any drainage down the back of the throat. There's no pus on the tonsils. The uvula looks midline. There's no unusual deviation there. And what I'm going to do is I'm going to test for the cranial nerve number 9 and 10. And the way we're going to do that is we're going to have Mr. Francisco open his mouth wide with tongue down and say, ah.
Ah.
Again?
Ah.
Okay. So what it is that uvula is vibrating when he says ah. So his cranial nerve number 9 and 10, they're intact. Okay. So now I'm going to go, you can go ahead and close your mouth. I'm going to inspect the inside of the mouth, and I will put on a glove. Okay, so go ahead and open your mouth. We are going to look at the dentition, making sure that there's no unusual cavities that are visible. I see that he has a few fillings. We're going to look at the gum area. No gingivitis, any swelling in the gingival area. I don't see any. Okay, so now stick out your tongue. Okay, we see that the papilla looks good. There's no lesions there. And go ahead and close your tongue. Open your mouth, I'm sorry. And I'm going to go ahead and look at the buccal mucosa. It's nice and pink and moist. Nice and pink and moist. The hard palate and then the soft palate looks good. Go ahead and lift your tongue up. And I'm looking at the salivary glands. They look good. There's no lesions. There's no masses. I don't feel anything in there that may be unusual. Now what we're going to go ahead and do, I am going to test for the cranial nerve number 12. The cranial nerve number 12 is in charge of the movement of the tongue. So Mr. Francisco, go ahead and stick out your tongue. Stick it back in. Okay, inside your mouth, touch the top of your mouth and down. Okay, so that's good. His cranial nerve number 12 is intact because his tongue is moving pretty well. No issues there, no deviation or anything. There's no swelling of the tongue and all of that. Okay, so now we are going to move on to the neck area. Now what I'm going to go ahead and look at, we're going to look at range of motion. So I'm going to have Mr. Francisco do a couple of movements, perform a couple of movements with his neck. Okay, so go ahead and touch your chin. Okay, now go ahead and hyperflex back to go pull your head back. Okay, now move your head side to side. Okay, now have your left ear touch your left shoulder. Okay, now the other side, your right ear touch your shoulder. Now shrug your shoulders and back down. Okay, now go ahead and push against my hand. Okay, now go ahead and push against my hand, and that's resistance. And he seems to have pretty good range of motion in his neck, and the neck looks symmetric. There's no asymmetry in the neck. I don't notice anything unusual. Also, I don't see a goiter. This is where you can actually look to see if there's any goiter, any swelling in the throat area. Now I'm going to take a look at the trachea. So I'm going to go ahead and feel the trachea. I see his Adam's apple there, but the trachea does not feel deviated. I'm going to go ahead and displace the trachea on one side and then the other side, which that's normal. We should be able to move it from one side to the next. And now go ahead and swallow. Okay, we can see him swallowing. Now we're going to take a look at the thyroid. Okay, so the thyroid lies right below the cricoid cartilage. And in this case, it would be right below the Adam's apple. So we're going to go ahead and find that thyroid, feel for the lobes. And we're going to go ahead and palpate for any masses, nodules. The isthmus is at the bottom, and I don't feel any masses or any swelling. Okay, go ahead and swallow. Okay, perfect. Okay, so now we're gonna go ahead and do a posterior check. Now we're gonna go ahead and have you face forward, and we'll take both of our hands and then find that cricoid cartilage again, right before that, right below that Adam's apple. And I can feel the lobes of the thyroid gland right there, and we'll feel for the lobes, no masses, no nodules. The thymus is right there, I can feel it. I don't feel any swelling, any nodules. Go ahead and swallow. Okay, one last thing that we need to do is we are going to look at the lymph nodes, palpate the lymph nodes, making sure that there is no swelling in the lymph nodes. They should be pea-sized and mobile. There should be no tenderness. If they are fixated and they're tender and they're hard and swollen, of course, then that's something that we need to look into further, investigate further, because that is not normal. So we're gonna go ahead and start with the way we palpate the lymph nodes with the 2 fingers in a circular motion. So we're gonna go ahead and start with the preocular lymph nodes, which are right in front of the ear. Okay, the posterior ocular. Okay. The posterior cervical. Okay. The occipital in the back of the head, or the occipitus. Okay. The anterior cervical. The submandibular. Submental. Okay, no swelling there. Now we're going to go ahead and look at the subclavicular, any lymph nodes above the clavicle. The clavicle is here. We're going to go ahead and feel for any swollen lymph nodes that are there. And infraclavicular, right under the clavicle. Okay. Well, seems like there's no swollen lymph nodes, so that part of the exam is intact with no abnormal findings. And this should conclude our HEENT examination. Thank you, Mr. Francisco.
You're welcome.